Well, Jay Hess is a wonderful next step in the evolution of this kind of engagement, because we now have, in the Dean of the Medical School, someone who is so entrepreneurial that he's actually started a company. And he started within the University of Michigan system a company called Paradigm, which is a nonprofit company and enterprise working in the diagnostic area. And he has learned within and seen within and been in charge within the University of Michigan system, which is a larger system in many respects than ours here, different from ours here, but similar in other respects. He has really been a key driver in working with the healthcare system, the academic medical center there, the hospital there, the university, and on his watch up there, we had Pfizer leaving Michigan and leaving the territory in Ann Arbor, and the university ended up coming in and taking over the Pfizer campus. Jay was the guy that drew the assignment to actually figure out how that was going to work and how to make that a productive assignment for the school. So again, the role of the dean of the medical school increasingly involves doing something creative, important, and economic development related with massive pieces of real estate. And that is still true here in central Indiana today, as all of you know. The whole strategy we have here, particularly in the downtown Mile Square, has a lot to do with the real estate of the medical school and the further development and future development of that. And I think you're going to hear a little bit today about, in fact, some of the school's plans for the development of what has been the old Wishart campus, again, sort of the next iteration of what's going to happen here. Jay is not a Hoosier native, but he's quickly learning his way around here. Originally from Connecticut, received his bachelor's degree in biophysics from Johns Hopkins University, as well as his MD and PhD degrees from the Hopkins School of Medicine. Interestingly, and he'll talk to you a little bit about this, I think, at one point, and early on, not so early on in the evolution of all this, but at a critical point in his career, he went back to business school and got an MBA from the Wharton School, because in his own career and life, these forces of academic medicine and business were coming together in new and interesting ways. And I think he'll talk to you a little bit about that today. So he, again, is living proof of the convergence of all of this. He has served for 8 years before his coming here as the Carl Weller Professor and Chair of the Department of Pathology and Professor of Pathology and Internal Medicine at the University of Michigan. Prior to that, he was at the University of Pennsylvania and Washington University School of Medicine. He is a serious scholar. He's published over 100 scientific papers. Very importantly, in what Dr. Hess does, he maintains an active lab, so he is a first among equals with the colleagues that he's working with. We have had the privilege of working with Jay since he arrived here in September. I am tremendously impressed with him, and all of us are who have had the great opportunity to work with him. His determination, his ambition, and his focus on what needs to happen next year, not only for the IU School of Medicine, but for the community and the state that's surrounded. We could not be in better hands. We could not have a stronger leader at the school. And we on the BioCrossroads team, who are fortunate to have Jay on our board of directors, felt it was very important for this community to get an early view of his vision. So we gave him about 4 or 5 months to settle in, and then said, please do a Frameworx session for us and let us in on where you think this is all going. And that's what we're going to do this morning. So Jay has some remarks for you. We are not going to have a panel. Sometimes we do, but today we're not going to have a panel because we really want to focus on him. And we hope very much you'll see a number of things in his presentation. Save your questions at the end, because we'd like to have a good conversation at the conclusion of his remarks. So Jay?
Thank you, Dave. Well, thanks for that kind introduction. I really appreciate the warm welcome I received in Indiana. I have no second thoughts about moving down here since September when I arrived. So what I want to do today is provide an overview of what we're thinking about at the School of Medicine right now and some of the plans and priorities that we have. It's not a complete plan, as you can imagine. There's still a lot of unfinished work to do. But it's always good to start with mission. And our mission is basically to improve the health of people in Indiana and beyond through our excellence and innovation in our 3 different missions there: education, research, and patient care. And if you think about our mission this way, every single person in the School of Medicine is in healthcare. Some of us are taking care of patients of today, and others are through teaching and research or finance or housekeeping or whatever. We're taking care of patients in the future. Now, that's our main mission, but we recognize in the School of Medicine that we also have an important role to play in the health of the community. So not just the patients who come into our hospitals, but actually people out there in the community we may not even have met yet, but we have a responsibility to do what we can to improve that health in the community. And the other is to do as much as we can to foster economic development in our environs. As many of you know, we're an unusual medical school. We're statewide. We have 9 campuses. The little triangles show where our medical centers are, and you can see the IU Health symbols showing the 18 IU Health hospitals across the state. We have over 1,300 medical students. We have nearly 300 PhD students. And our main clinical affiliate is IU Health, but we work closely with the Eskenazi Health System, the VA hospital, but we actually have affiliation agreements with over 50 other different hospitals and clinics. We're currently the 2nd largest medical school in the U.S., but will soon become the largest. So when you think about the kind of footprint we have across the state, we really are in a position to influence the healthcare patterns, across the entire state of Indiana. We train the majority of the physicians in Indiana. If you look at our medical school, more than half of our graduates will actually ultimately end up practicing in the state, and that's one of the highest. You can see the 6th in the country. So we have a big role to play in healthcare in Indiana because we actually train the majority of providers. Now, the demand for a medical degree from Indiana University has never been higher. This year we had over 5,000 applications for approximately 325 slots in medical school. That's a 40% increase over the past 2 years. And if you look at, well, where's the growth coming from? It's actually out-of-state applicants. So we're actually becoming a more competitive medical school each year. Now, the reasons for that aren't entirely clear, but I think one thing to note is that IU Health, so one of our main clinical partners, is recognized on the U.S. News and World Report honor roll as one of the top 1% of hospitals in the country. U.S. News and World Report also ranks medical schools in 2 different categories, in research and in primary care. Now, we last year moved up a couple slots in research from 48th to 46th. We're going to keep moving on that, but we were really pleased to move up 19 in the rankings in primary care from 37th to 18th. And I think that tends to reflect the focus that we have on improving patient care, and we'll talk more about the types of programs we have that are not just for the metropolitan areas, but in rural health and improving the health of people across the state of Indiana, both underserved and not. There's no shortage of challenges in healthcare right now. As I think many of you realize, we're spending $2.8 trillion on healthcare right now. And on a per capita basis, that's double what the next closest country, Switzerland, does. And yet if you look at our overall healthcare outcome, we're dead last among industrialized countries for our overall health outcomes. So we're not getting the results we really should be getting for that level of investment. We're also, as a population, becoming older. We're an aging population. We're very sedentary. We don't have a particularly good diet. And so what's happening is that we're looking ahead and seeing that we're going to have a lot more chronic disease in the future. We face an epidemic of chronic diseases. And we don't have enough physicians to take care of everyone. We know that. And just increasing class size isn't going to get us there, because there's a bottleneck in graduate medical education. After you've gotten your MD or DO degree, you still need to do a residency in some area. There are not enough physicians to do that, and even if you expanded the number of graduate medical education slots, we still have a problem in the US because we've never gotten serious about where physicians go after they train. So even if we doubled the number of physicians, they'd still tend to cluster more in the major metropolitan areas and not go out in the rural areas where they're needed. Actually, our School of Medicine has done a very good job of training people who go into primary care and stay in the state. 42% of all our graduates actually go into primary care. And because of our regional campus system, they actually tend to stay in those areas. So we're actually doing much better than the average medical school at doing that. Now, payment models are changing dramatically. So traditionally, we're paid for taking care of sick people who come into the hospital or into our clinics. So it's a very volume-driven reimbursement model right now. And this is getting turned on its head now with a variety of changes in the way Medicare is paying for care as well as commercial payers. And so we're really trying to move from a volume-driven world to a value-based reimbursement model. And that's going to require a lot of re-engineering of the way we provide care. And just to provide a graphic representation of how the United States is really a healthcare outlier, you can see this is a plot of life expectancy versus per person expenditures on healthcare. And you can see there's a pretty clear relationship between that, except look at the United States. We're completely off the curve. There's something very different going on in the US, and a lot of this is driven by the fee-for-service world that we're working in, as well as our new technology and all, which is driving up costs and not necessarily improving health. How do we fare in the state of Indiana? Unfortunately, not very well. If you look at most of the major indicators of health status, infant mortality, premature death rate, overall healthcare status, we're below average for the United States, which is way below average for industrialized countries. So overall, 41st in overall healthcare status. So a lot of opportunity for improvement there. So if you look at what do we need to do in healthcare right now, many of you have probably heard about this idea of the triple aim. Actually, the Affordable Care Act was really designed to try to address all three elements of the triple aim. We have to improve the health of populations, we have to improve the experience of being a patient, and we have to try to drive down the per capita cost of care. So in everything we do in the School of Medicine, we're trying to work on these three axes. You know, we don't just want to drive new technology in that's going to increase the cost of care because resources are limited. We have to think about the overall goals of what we're trying to do. The research challenges, it's a very exciting time in research. It's amazing, for example, that we basically have the genetic blueprints for the common types of cancer. The major killers of men and women, we know most of the genetic lesions. We don't understand all the pathways that they involve, and we haven't developed drugs for all of those, but we've never been in that position before with cancer, and it's similar with other diseases. The problem is that the funding to take these discoveries to the next step has been declining in real dollars now for more than a decade. And of course, that puts a lot of pressure on our investigators when only 5 to 10% of all the grants that are submitted will get funded. There's a great deal of work going on just to keep the lab funded, to keep moving ahead, and that's a challenge we have to address. There's a bottleneck in clinical translation. We've made some spectacular discoveries that are fundamental, and yet we don't see the translation of that into improved health yet. That's true not just in academics, but also if you look in the pharmaceutical industry, and R&D spending continues to climb, and yet the number of new drugs that are being licensed continues its downward decline. So that's another big challenge. There's hyper competition for talent and funding. So people with multiple grants are recruited away. We have to successfully compete with prestigious schools on the coast and all to recruit people into Indiana. And then just in general, we talk a lot about innovation, but we need more. We need more, not incremental discoveries, incrementally building on findings, but we really need to recruit very creative people and give them enough space so that they can make mistakes and learn, from them and ultimately move the field ahead. And I still think there's not enough collaboration. So we have every university in the United States that's research intensive builds the same research infrastructure. So our limited tax dollars basically are building competing parallel operations across the country. We have to think about how to do that differently. How are we doing at the School of Medicine? We actually had eked out a slight increase in our overall funding, which is about $250 million a year. But the thing that's the concern, the gray bar there, is that our NIH funding has actually been drifting downwards and was down 10% last year. We'll talk a little bit more about some strategies for how we'd like to reverse that. Education challenges. We know that the healthcare providers of the future have to work together on teams. It's very interdisciplinary. We need physicians and nurses and social workers and all working more effectively together. They're going to need to know how to use electronic medical records and other apps that we haven't even thought of yet in terms of how we're going to manage patients in the future. I'd say with our current generation, that's not a big problem. They pick it, they're picking it up pretty quickly. But that whole idea about being able to lead change, have more effective leadership skills, get used to the idea of working on a team and actually being held accountable for the overall results of the team and even for the system, and moving away from that Lone Ranger model of medical care that we've really gotten accustomed to. We need to increase diversity, not just in our students, but particularly in the senior ranks of faculty and in faculty leadership. And there's a number of efforts going on in that area. Medical student debt, the average medical student debt for an IU graduate with debt is $157,000. Now that has some important implications because the next line there you see undersupply of primary care providers. In our current reimbursement model, the lowest paying medical areas are in primary care. So the higher the debt of your graduates, the less likely you are to be able to get people into some of the areas where we really need the most physicians. So our vision is to be one of the premier medical schools in the nation based on our education and scientific investigation and healthcare delivery. Of course, every academic medical center's vision statement says something like this. So I thought, well, let's talk a little bit about how we see ourselves doing that. And just a simple little graphic here, which we're going to walk through, that really kind of shows our mission is to improve health. The foundation for that is excellence. That means we're going to recruit the very best talent we can. There are going to be rewards for high performance. There'll be consequences for not so high performance. It's easier to say that than to actually implement it, but we are. And really, how do we truly innovate, scientifically with new business models, new ways of working together that are really truly creative and not just kind of incremental changes from what we've been doing. So let's walk through these. The first area, I truly believe that IU can be a leader in the nation in population health management. And that's that whole idea of rather than waiting for people to develop their illness or their chronic disease or not get their immunizations and then get hospitalized with a viral infection in the ICU, let's manage a group of patients and keep them healthy. And we have a lot going for us. We have the country's top health informatics research institute, the Regan Street Institute. We have developed a Center for Health Innovation and Implementation Science, which I'll talk a little bit more about. We have a tremendous experience in delivering low-cost care in third world countries through our AMPATH program, which was originally started to address the imminent death of tens of millions of Africans from HIV infection without effective therapy. And 20 years ago, a group of our faculty got involved in this. Other universities have joined, and it probably saved the lives of millions of Africans in Kenya. We have a a rural medicine program in Terre Haute, Indiana that's really quite an interesting model too. When medical students apply to Indiana University, our staff look at what part of the state do they come from. And if they come from an underserved area, there's a program in which, with some scholarship support, they can actually get assigned to that regional center and do their training there and learn more about how do you deliver healthcare in a region where you don't even have one of each of the healthcare specialists you need. You really have to be able to provide a whole range of emergency health services and everything else out in the field. I was just out at Terre Haute this Friday for the graduation of one of the first cohorts of these students, and they really find this to be a very energizing career for them and all. I don't know a lot of programs like this, but this is an example of how people say, well, you can't get people to work in rural areas and all. Well, we have something that seems to be working. And then we have 7 other health sciences schools on our campus, and so in my other role as Vice President for University Clinical Affairs, we are actually working together. These 7 health sciences deans, we meet monthly, and we have a number of initiatives underway, in particular in promoting interprofessional education. And then a grand challenge project in population health. This is something that we're just examining right now, but whether it's pediatric obesity or infant mortality or pediatric behavioral health, we would really like to be involved in a project that engages people in the community the way we did in AMPATH and are doing, but in our backyard instead of in Kenya. Now, one of the things that I think is very interesting when we think about really trying to improve health, and that is, well, what are the inputs for good health? What are the determinants of good health? And this is a very interesting pie chart, I think, because the green wedge there, the 10% of overall health, is related to what kind of health care can we actually get. So we've been pouring $2.8 trillion as a country into the green wedge here, the 10%. But look at some of the others. So the 15% of your overall health outcome is, well, what kind of people do you associate with? And environment. What's the water like that you breathe, or the water that you drink, the air that you breathe? Human biology. What are your genetics? How well did you choose your parents? I mean, you have and then lifestyle and behavior. Do you like riding your motorcycle without a helmet? Do you like drinking and driving? And rock climbing without ropes and so forth. I mean, there's a lot of different things that when you think about it, we always reach first for the medical model, but there are other things that we could do that might not be that costly that would work out better. And this is the way we have to look at the problem. Now, the Center for Health Implementation and Innovation Sciences, it's a very interesting new center. And the basic idea is we can make a process in the hospital more efficient, but it might be the wrong process. How do we actually, in a systematic, scientific way, look at healthcare delivery and map out, well, what are actually the beneficial steps in this process, and is there a different way of doing it? Well, there's actually a whole science of how to look at problems like this, and we need to train a whole new generation of healthcare providers that are better able to look at problems and re-engineer them and all. And we have units assigned to Eskenazi Health, to IU Health, to Riley Children's Hospital, and to the VA hospital. And then, very importantly, find the solution, measure the outcomes of it, and then disseminate it across the system. And there's actually a master's degree program. There's a certificate program, and there's going to be a master's degree program in this that we think, not just MDs, but potentially some nurses, social workers, others may be interested in pursuing. The second pillar is to build research programs that'll be one of the top 2 in the country. And it's interesting, when I first arrived at Indiana, I immediately sensed this unease about being that out there about, setting a really high goal and all, and, say, do we really need to be one of the top 2 in the country? The thinking behind this is when federal funding and research funding is only going to fund the top 5 or 10% of grants, we have to find a way of being in that top 5 or 10%. And to do that, it means we have to focus. We just can't do everything. We have to pick some areas where we have some strengths and build on them so that we can really be competitive. And I think this is another one of those things. It's easy to say that, but it takes a lot of discipline to really work together and say, we're going to do this and not that. We're very enthusiastic about bench-to-bedside programs. So if we're going to build a program, let's not just build the basic science part and leave the rest off. Or let's not just run clinical trials but have no basic science underpinning. But let's figure out, how do we link up, the basic science investigators, the translational researchers, the clinicians, get them to work together and provide them with the resources that they need. Of course, we hear a lot about team science and teamwork and all, and it's good to provide people with tools of how do you work together better and all. But what we're thinking about here is we need to recruit the team, right? So if you have some people that you need in order to be successful, you've already identified what your research priority is, what your goal is. Let's sit down and start talking about, well, what's the expertise we lack to keep us from being one of the top programs in the country. And so that's a lot about what we're talking about with teamwork. And then accountability, we hear about that all the time. But if you're a high performer and you're bringing in a lot of grants and all, you need to be recognized. If you're someone who hasn't written a grant in 10 years, we have to address that because there just isn't enough in the system to be able to support everyone at the same level. We have to, sometimes they call it, giving the basketball to the 7-foot center. I mean, you're probably going to do better. We have strong support with the Strategic Research Initiative. IU Health, together with the School of Medicine, is each putting $75 million over a 5-year period into strategic investments in cancer, neuroscience, and cardiovascular diseases. And again, we want to identify and invest in areas that we can be one of the leaders in the country. As you travel around to other medical schools, I think almost everyone you see will list these 3 as their priorities because they're the major health problems that we're going to face in the future. So what we're doing right now is really looking at where in these areas can we really make a difference here at IU. And we have found a number of examples of areas in which we are truly leading in the country. We've also, together with our clinical partner IU Health, have made some pretty big investments in facilities. And I think many of you have driven on 65 by the new Neuroscience Center. Well, it's a pretty innovative place because you see on the left there that's where our research laboratories are. And our general philosophy is let's organize our researchers not by department, but let's organize them thematically on what they work on. And so you can see here, that top floor there, we're very strong in traumatic brain injury, neurotrauma and all. Many different departments are working together in that floor, mood disorders, addiction. So you can see it's organized that way. And then interestingly, across the hall is where our clinicians are. And it's not just neurology, but neurosurgery, psychiatry, and physical medicine and rehabilitation. So it's highly interdisciplinary. And then in between, there are these interaction areas, where you have lunch and everything. And so that the building fosters this kind of interaction. And it's really a beautiful facility. We want to speed the pace of discovery and clinical translation. We are very grateful for the support of the Lilly Endowment, which provided us with a $60 million gift to support the recruitment of physician scientists, as well as an endowment for our MD-PhD program. We are going to be creating a Center for Chemical Biology and Drug Development on our health sciences campus. I'll show you a slide of that in a moment. This is a 120,000 square foot building, and I'll talk a little bit more about how we see that interacting with the other universities in the state. We want to facilitate more public-private partnerships. We have started a business engagement portal, which will be up and live soon, so that if you're in the private sector and you want to know what expertise is available in the IU School of Medicine, we'll have navigators for you to help identify. This is the expertise we have. Or if you need a particular, let's say, assay developed, we will assemble a group of experts that can do this. We'd like to have deeper collaborations with other universities. For example, why not have joint faculty appointments between Purdue? I mean, we already have a campus that we share, but why not have a situation where the faculty member actually has a full, like half their appointment in Purdue or Notre Dame and half in the School of Medicine? Because as we travel around the state, one of the biggest challenges that other universities, Purdue, Notre Dame, IU Bloomington, one of the biggest challenges they face is when they try to recruit, what they hear is, you don't have a medical school. Right? We can help with that. And then the CTSI, I believe last year, Anantha Shekhar presented a presentation on the CTSI. I view the CTSI as an incredible asset for the entire community. It's a remarkable, this is the Clinical and Translational Sciences Institute, and it brings together Notre Dame, Purdue, Indiana University, our corporate partners, the state, the Regan Streif Institute, the Lilly Endowment, the Fairbanks Foundation. This is an ecosystem for promoting, research on health in the state, and it actually, I've traveled over quite a bit of Indiana. Now, it's hard to find a place in Indiana where this program has not had a big impact. Now, a little bit of a complicated slide here, but the basic idea is if you look up there on the upper left, if you're an investigator, if you're someone in the community or a trainee and all, you can go to the CTSI website, and there's basically a button on the upper left that says, do you need help? And you click on it, and it brings you to a navigator. And then what are some of the things the CTSI can do? Down here, it's a little hard to see there, but that first box, the project development teams, you're an investigator, you have an idea about a potential research project, but you don't have all the expertise you need. Maybe you need access to the Indiana Health Information Exchange, and you don't know how to do that and all. Project development teams bring in the expertise you need and basically help navigate you to a successful project. If you're doing clinical research, well, you may not know how do you get an IRB approval? How do you monitor your research? And where do you get biostatistics help for analyzing your data? There are people that are employed by the CTSI to help with this. And then there are a variety of career development programs and training people how to do particular types of scientific procedures. Now, all of this leads to successful outcomes. And in fact, this was the first submission of the CTSI grant, which was funded. And we thought about it, and successful outcomes in academics usually means you published a paper, right? And we're really concerned about, well, that's good, but what we're really here to do is improve health and all. How do we take that next step? And so in the resubmission, or the renewal of the CTSI, which I will say got the second highest score in the history of the program, and was renewed for another 5 years at full budget, is how do we go from kind of the academic progress to real impact on health? And so the idea here is, I mentioned that Center for Health Information, Health Innovation and Implementation Science. So that's actually going to be embedded in our partner healthcare systems to try to re-engineer patient care. Entrepreneurship programs, how do we foster more interactions between the public sector and the private sector? How do we help our faculty license their technology or develop it potentially in a company that could employ people here in Indiana? And then the community health engagement program in the CTSI is part of that community signature community public health project, in which we work in a rural area and an urban area in Indiana as kind of a laboratory for how do we engage the community there and through some of the insights that we're getting, improve particular health metrics and all. So that's the overall idea, going from just academic publications and all to let's really extend this out into the real world. Now, the other thing that we are working on is we do a lot of clinical research at Indiana University, and I think it's fair to say people who have been in Indiana a while would say that Indiana University is not the easiest place to work with. We're slow, we're bureaucratic, we can't turn contracts around and all. I just want to assure you there's been a lot of work on this in the area of clinical research led by Anantha Shekhar. And the idea is there'll be a single point of entry for clinical trials that you want to run at the School of Medicine, in which you can reach into the IU health system, into all 18 hospitals in that system, as well as Eskenazi, potentially other partner hospitals, so that you can enroll patients quickly. And we've been very focused on efficiency and on metrics. And actually, Eli Lilly has loaned us a lean expert who has value stream mapped the entire process and dramatically reduced the barriers to getting things done quickly in this, and we're very grateful. So just to show you a little bit of evidence of our improvement, so the top set of bars is just how long does it take to get an institutional review board approval? This is human subjects approval and all, and this can take months when things aren't going well. But you can see there's been a dramatic reduction in the time to get approval for expedited review. It's 12 days now, and that's not bad at all. And then to get contracts signed, you know, we recognized one of our barriers was getting things through legal. So, okay, well, let's figure out, you know, how do we expedite that process and all. And we have further, this only goes up to 2012, but we're going to continue to track this. And so because of our large size and our efficiency and all, we want to be a place where people will come to run their clinical trials here. Now, why do we want to do that? It's not just because that's a source of revenue or something. It's also because clinical trials, phase 1 trials, are a way of providing the most effective or the most innovative therapies for patients. It's good for patient care to be able to go to a place that's offering the cutting-edge therapies that are not standard of care at other places. And so we have partnered with Covance to establish a phase 1 unit at IU Hospital. And a phase 1 unit is where it's the first test of drugs in the field and all. And in many areas, they're just toxicity studies and all, but we're not really interested in that. We want phase 1 agents that are likely to benefit patients, particularly in the area of cancer and autoimmune diseases. And in fact, the Covance partnership is going to be focused primarily on autoimmune diseases. And then university partnerships. This was another part of the CTSI grant, developing an Indiana Molecular Therapeutics program. As you probably know, Purdue has opened a drug discovery center. Notre Dame is very interested in this, and I mentioned, you know, we have plans to do the same thing on our health sciences campus. So how do we figure out, again, how do we maximize synergies here and not just kind of compete for the same talent across the state and invest in the same instrumentation and infrastructure? And this is really work in progress. You know, how do we maximize the impact of having, for example, in the state of Indiana, IU Bloomington and Purdue have two of the strongest chemistry departments in the United States. We have a tremendous clinical research enterprise at the IU School of Medicine. We have pharmaceutical companies in our backyard and all. But how do we get all of those elements, you know, working together in more of a collaborative, synergistic way and not just competing for talent? And that's something that we're working on right now. Now, I just wanted to mention the Health Sciences Park. I think many of you are familiar with the former Wishart campus, where Wishart Hospital was and all. We're actually have done a lot of master planning for this site, and I think this summer you're going to see a number of buildings coming down on that site. The ones in red will be, there's really about 500,000 square feet of space that's so old and all that we're going to demolish that for the time being. But some of the components of the Health Sciences Park include the Regan Street Institute, which is going to design and build its own building on the site. We have a new health education building, which will be not just for the School of Medicine, but all of the health sciences schools. This is going to be an interesting cultural experiment. We're really trying to advance interprofessional education. So not only are we going to share classrooms and a simulation center, but also the library and common areas and all. The students from the different schools are going to interact together. And so we're not just going to transform a curriculum where we're going to train the different providers together, but they're actually going to, it's going to be a socialization as well. The Center for Drug Discovery, funded from funds from the state to create new laboratory space there, which may be a site for the IBRI or temporary space for the IBRI. The School of Dentistry, and very importantly, we now, through the support of the Fairbanks Foundation, have a new School of Public Health, which will also be on this campus. So just as I had done in my previous life at Michigan, we recognize this has to be a vibrant health sciences campus with amenities and good parking and access and all. But you'll see a lot going on over the next several years on this part of the IU campus. The training providers who lead the transformation of healthcare, just very briefly, we're expanding our medical school to 4 years on all the campuses. So we have actually, at any of the regional campuses now, you can do the full 4 years, and a lot of that is through the support of our 2,600 volunteer clinical faculty who provide the clinical rotations on these campuses. We have a revised curriculum so that now we will have across all 9 campuses a updated curriculum that's standardized and will help keep us in compliance. It's all going to be delivered, of course, electronically, and you probably heard the expression flipped classroom. Well, there's almost no lectures face-to-face anymore. It's like those lectures are all online, and then if you're going to have interactions, it's going to be discussions, working in small groups. There's much more of an emphasis on that and active learning, and not just passively sitting there in a classroom. I mentioned the master's degree in implementation science, and also with our development office and all, we really have had good success in increasing our scholarships, the number of our scholarships that we can offer so that we can really continue to attract top students. So I just wanted to mention one, I think, very innovative aspect of our curriculum, and that is that we have a program that was, there were 119 schools that submitted proposals to the AMA for $1 million grants to really to promote innovation in education. And we were one of 11 schools that were actually awarded a grant. And our program is an electronic medical record that has real patient data in it. And the students are actually going to manage a panel of patients, and things are going to go wrong with them and all. They're going to have to order tests and make diagnoses and make decisions. And running in the background is an analytic program that will say, you know, an experienced clinician would have done this, and you did that. And another interesting aspect of it is that they will actually be aware of the costs of what they're doing. So if they order a series of tests, they go down a certain route. For the first time, they're actually going to get an idea, well, you know, there was a better way of doing this that would have been made better use of our precious resources and all. And then just a couple of final points. This is, in terms of strengthening faculty vitality, you can imagine with the demands on our clinicians, with only 5% of grants being funded, we're revising the curriculum, we're raising expectations. There's a lot of, our most precious resource are our faculty and staff, and there's a lot of pressure on them right now. And so we're working to, we've done a lot of work on upping our game in recruiting. We're successfully recruiting people from the coast and all. We have, in terms of faculty mentorship, in a more targeted way, if you're rolling out a new curriculum, let's train our faculty to be able to do that, not just in a general mentorship like having coffee or something, but bring people in and, okay, here's the new software we've got to use, and here's how we're going to run these, you know, how can we help? Some of our basic scientists are finding themselves where they have to teach some clinical areas that they didn't have to do in the old curriculum. Well, they need help, you know, they need the support and all. And then there's faculty flexibility. This is an area we'd be very interested in working more with other universities and also with other, you know, the private sector. How do we find jobs for the spouses? How do we make our work environment more flexible? How much can we actually do from home? Or, you know, more flexibility in the workforce would be helpful for us. And then we have a lot of work going on in terms of revitalizing our programs to foster more diversity. And then moving from silos to a system. If we're going to succeed in population health, whether it be through IU Health or Eskenazi or other health partners and all, we've got to figure out a way of getting more alignment and integration. And those could be financial models, it could be more shared decision making. So we need to find these structures for better integration and alignment. And just to emphasize one last time, we're all about more collaboration, more deeper, more meaningful collaborations. That could be between the health sciences schools. It could be closer relationships between universities so that we don't just go out and invest in the same equipment and compete for the same talent, but pool our expertise in a way that we actually then collectively as a state become one of the top programs in the country. And then our soon-to-be-launched business engagement portal.